I, Sanjeev Kanchan, National Coordinator, Isha, Special Interest Group for Speech, welcome you all to first session of Fluency Friday series. It is moment of great pleasure to welcome all the attendees present here today, including private practicing SLPs, faculty member of leading institutes, and students. There is a famous saying, knowledge has to be improved, challenged, and increased constantly, or it vanishes. So, as clinician, it becomes very important for us that we keep ourselves updated to serve best to our patients. Isha Special Interest Group Speech is going to organize 4 scientific sessions on fluency on every Friday this month, followed by panel discussion on last Friday of September. SIG Speech is delighted to have 4 young and dynamic researchers to make this event a grand success with their presence. Now, moving on to today's topic, overview and assessment of stuttering. It's great pleasure to welcome Dr. Santhosh for today's talk. Dr. Santhosh is presently Professor, Speech Language Sciences, All India Institute of Speech and Hearing, Mysuru. In his professional career of over 2 decades, Dr. Santhosh has number of national and international research publications, awards, honors to his credit beside being member of editorial boards. We welcome you, sir. Now, I would like to make another important announcement that on SIG speech request, Dr. Santosh drafted and prepared a standard stuttering assessment protocol. SIG Speech has submitted this protocol to Isha committee for evaluation. Once approved, this will be available as ready reference to all of us. And I am hopeful that on a day of panel discussion, special interest group speech will be making it available on Isha website as resource material. Now I request Dr. Santosh to begin with his presentation. We
Thank
welcome
you,
you, sir.
Sanjeev, sir. Thank you for that nice introduction for the whole webinar on stuttering. At the outset, I thank Isha for giving us an opportunity to present our views regarding the stuttering. So this is like Sanjeev sir suggested, this will be a 4-week kind of a webinar where every week, 1 hour maximum, we will be talking about different aspects of stuttering. I'll start with giving a brief overview on stuttering, and as well as I'll talk about assessment of stuttering both in children and adults in today's webinar. Okay. My slides, I believe, visible to everyone. So in today's this one, I'll be giving a brief introduction to stuttering. So, like I said, the main purpose of this seminar is to introduce what is fluency, what is stuttering, talk about assessment of stuttering, which I'll be doing it in today's hour, and in next subsequent weeks we will have others presenting on management of stuttering in children, school-going children, and adolescents and adults. Okay, so let's get started with these terms which we come across: what fluency, DIS fluency, and DYS fluency. I still, so many people ask me what is the difference between DIS fluency and DYS fluency. There appears to be some kind of a confusion in using these terms. So the main word fluency, it refers to smooth flow of speech. Whereas DIS fluency, that is disfluency, it refers to normal breakdowns in fluency, which we see typically in everybody, in all of us.
Sir,
Whereas
1 minute.
DYS fluency, that is disfluencies, are abnormal breakdown in fluency, which we commonly see in persons who stutter. So when we talk about fluency, like I said, it's a smooth flow of speech. So the smooth flow is with respect to continuity, which is devoid of any kind of hesitations, repetitions, prolongations, blocks, etc. Also, when we say fluency, fluent speech is uttered at a rapid rate, it's rhythmic in nature, and it is effortless in nature. So when we say fluency, I was saying that it's a smooth flow of speech with respect to continuity. There should be a rate of speech which is uttered at a rapid rate, it is rhythmic in nature, and it is effortless in nature. So there are different fluency disorders. like stuttering, cluttering, neurogenic stuttering, and fast rate of speech. This webinar we are only talking about stuttering. So the main components of fluency, as I suggested, are continuity, rate, effort, and rhythmic structure of speech. So we'll move on with the stuttering. So stuttering is an age-old problem. So it's been there since the brain has evolved for speech and language. Okay, it typically happens. The onset of stuttering typically happens when other communication skills also developing, like emotion, cognition, etc. When I talk about age-old problem regarding stuttering, stuttering has been noticed since humans are using speech for communication. To give an example how it existed in the previous era and all those things, this is a image which is taken from one of those Egyptian museums, where you can see in the image, right, there is this symbol given which suggests breakdowns in speech. We breakdowns, and this breakdown is typically is referred to speech, because as you can see, the person is pointing towards his or her mouth. Okay, so it refers to impediment in speech, impediment in the smooth flow of speech, or in other words, what we call it as stuttering. So this has been documented right from the Egyptian era. Okay, so when we talk about stuttering, typically most of us might have come across this Sheehan's iceberg analogy. Okay, it has stuttering. What we typically observe outside is only in terms of repetitions, prolongations, and blocks, which is only a tip of the iceberg. Only what we observe as overt features of stuttering is only a tip of the iceberg. Besides this, there is this bulk of the iceberg, which is the hidden mechanisms, which is leading to the overt features. They are the bulk of the iceberg. So whatever we observe is only the tip in terms of repetitions, prolongations, and blocks, and you have bulk of the characteristics hiding below the surface. Okay, so there are these core behaviors of stuttering. According to Van Riper, these core behaviors are repetitions, prolongations, and blocks. These core behaviors are involuntary. That means to say that they are not under the control of the person whoever is stuttering. Okay, so the repetitions are in terms of sound, syllable, or part word repetitions. Prolongations could be voiced or voiceless prolongations, and blocks are broken words. To give a simple example, when I say repetitions, typically the stuttering repetitions are like cricket. Okay, it is in terms of sound or syllable repetitions. Okay, so Mysore is a part word repetition. Then you have prolongations like Mysore, where he is prolonging the sound for a longer duration. It could also be broken words or blocks. Blocks in terms of like going, where there's articulatory fixation as well as there is a cessation of the airflow. Okay, so these are the core behaviors of stuttering, which we speech behaviors which we typically observe in most of the stutterers. The secondary behaviors also are associated with these core behaviors. At the initial stages, you may not observe the secondary behaviors when the child is just started stuttering, but due to learned mechanisms, they start appearing at a later stage. So these secondary behaviors could be of two types. They could be of escape type of behaviors or avoidance kind of behaviors. Okay. So what are these escape behaviors? Escape behaviors occur during the instance of stuttering. As soon as person knows, he got the disciplined episode, so he wants to terminate that initiated disciplined episode as quickly as possible. So at that point of time, he could associate one of these behaviors with those disciplined episodes. It could be in terms of eye blinking, it could be head nods, it could be jaw jerks, it could be any kind of extraneous speech sounds. Okay, so these types of behaviors are initiated after the discipline episode has started. Okay, the next set of behaviors are avoidance behaviors. This is much more well learned mechanisms when compared to escape behaviors, where as soon as person anticipates that is going to stutter, so he wants to avoid that stuttering instance completely. So before the occurrence of stuttering instance, whatever he does, they are those avoidance behaviors. These avoidance behaviors could be like, for example, change of the word he is planning to say, switching, code switching mechanisms, switching from one language to another language, etc. Okay, so avoidance could be like completely avoiding the situation, avoiding the person, avoiding the language, avoiding that particular sound. It could be any different kinds of avoidance behaviors.
Excuse me, sir.
Okay, so the main core behaviors are the repetitions, prolongations, blocks. Okay, so I was just discussing about the characteristics of stuttering. I just said the stuttering is an age-old problem. It's seen since humans have started speaking. Typically, stuttering individuals have these core behaviors, secondary behaviors, and feelings and attitudes. The core behaviors are in terms of repetitions, prolongations, and blocks. The secondary behaviors are, it could be in terms of escape behaviors and avoidance behaviors. And the feelings and attitudes are the third set of characteristics which can be seen in individuals who stutter. So, for example, the negative feeling towards speaking, towards listeners, towards their own stuttering. Okay, it could be negative attitudes. Okay, so in this example, as you can make out, when the girl asked him, "Where did you go last weekend?" He has this negative feeling that, oh no, I'll never get this word out. She think I'm really dumb. This is kind of a negative feeling he has towards his own speech. Okay, so apart from what we typically observe as repetitions, prolongations, and blocks, these individuals also have changes in their attitudes, increased anxiety, all those things. So we, as a clinician, we need to be aware of these behaviors so that we can target these behaviors during our therapy. Okay, so typically stuttering begins between 2 to 5 years of age. In most people, the developmental stuttering starts between 2 to 5 years of age. The triggering factor for the development of stuttering could be anything. It could be some kind of a stress which has occurred at home. Okay, when I say triggering factor, like imagine there are two children at home. There is a first child and a second child. First child develops completely normally fluent speech. Second child, he's developed stuttering. Now parents will come and ask us, well, how come my first child didn't develop stuttering, my second child has developed stuttering. Okay, it could be both. The children may be susceptible to develop stuttering. However, the environmental factors may be different between these two children. There could be some kind of a stress in the early childhood. For example, baby brother is or sister is born. When you move your family from one environment to another kind of an environment, a new environment acts like a stressful situation for the child. When there is a rapid growth of vocabulary, syntax, that can act like a load on the speech motor system of the children. Okay, so it could be combination of one of these factors, or all together can trigger the development of stuttering in those children who are susceptible to develop stuttering. Okay, so this is a typical example. I use it in my class also, where you can see that genetically the child is predisposed to develop stuttering. There could be one of the family members who had stuttering, so that genes get transferred to this child also. So the rapid development in speech and language skills may trigger the initial stages of stuttering, and the way parents are correcting the child's stuttering episodes, that can precipitate the development of stuttering. Okay, on top of it, when the child starts going to school, the bullying by the other schoolmates can again lead to development of negative reactions, negative attitudes, fear, phobia, all those things. And by the time the person has reached his adolescence, he would be like in a completely full blown persistent stutterer. Okay, so this is the way we will see the development of stuttering happening in most people. So how individuals differ from one person stuttering to another person stuttering? They can vary depending upon how much they stutter in terms of their frequency. One may be a very mild stutterer, another may be very severe stutterer. Every sound he will have stuttering episode. Okay, or in terms of the kind of speech characteristic they are exhibiting. There could be one individual with lots of part word repetitions and pronunciation. There could be another individual with lots of broken words and blocks kind of a thing. Okay, so depending upon their frequency and nature of stuttering, these individuals can vary from one to one another. On an average, we see more stuttering in spontaneous speech when compared to reading. Okay, typically the disciplined episodes could be on an average for us 1 second. In rare cases, it can go up to greater than 5 seconds. Like I said, causes, we still don't know what causes stuttering. What is the causative mechanism which makes these individuals to go in terms of repeating sounds, prolongations, or blocks? But there is now a strong genetic evidence for the development of stuttering. That means to say that there are specific genes have been identified in those individuals who stutter. GNPT-AB gene, GNPT-AG gene, NAGPA gene, all these genes have been identified, and therefore mutations in genes which can lead to the development of stuttering. Okay, like I said, not all individuals who have mutations in these genes will not develop stuttering. Along with these, genetic predisposition, environmental factors, development of speech and language, the way they react to the stressful situations, all those things collectively will lead to the development of stuttering. Okay, so there are some evidence now that there are changes in the way neural connections, both gray matter connections as well as white matter track connections, in individuals who stutter are different, right? As early as early childhood. Okay? So how do we diagnose stuttering? So when do you say the person may be having stuttering? What could be kind of a common criteria which can be used when you say that the person may be stuttering? So if the number of disfluencies, frequency of disfluencies exceeds 5% of spoken words, then you can term the person as disfluent or stuttering person. This is a common, valid, practical diagnostic criterion, according to me, which can be used by most individuals. Okay. So with that brief introduction, I move on to my second presentation, that's on the assessment of stuttering. I hope my first part of the presentation is clear to all of you. We will take question and answer session at the end of my second presentation. So we'll move on to the second presentation, that's on the assessment of stuttering. So in this presentation, I'll be mainly talking about how we do the assessment of stuttering in children and how we do this in adults who stutter. Okay. So first question, as a clinician, as a practitioner, I should be asking when I have a 3-year-old child coming to my clinic, with disfluent speech, whether the child has a fluency disorder or not, or if at all, if he's showing those disfluencies, is he at risk for development of stuttering? What type of fluency disorder? If you see some kind of a abnormality in his fluency, whether it is stuttering, cluttering, etc. Okay, you need to understand the nature of the disorder. If it is stuttering, what is the nature of his stuttering? What is the severity of his stuttering? And we need to also assess progress. When we do assessment, you give therapy, post therapy, how much is the change. So you also need to do assessment before therapy and immediately post therapy in the follow-up sessions. So assessment we do at all these stages. Okay. Initial assessment, we start by taking a detailed case history. Like Sanjeev sir suggested, we have come up with a common protocol which can be used by all the practitioners. It's a simple protocol. We document the general development of speech and language skills, academic performance, social behavior of the child. We describe the problem in this case assessment of case history, all those things. When the child started showing the disfluencies, what is the nature of the disfluency at the beginning? Have the nature of disfluencies have changed over the period, like since the onset to the current evaluation? And is it increasing or decreasing? That's what I mean by that. And what is the parents' reaction to those disfluencies? What is the child's reaction to those disfluencies? What kind of coping mechanism the child is using? All these things need to be documented when you take a detailed case history. Okay. So, but like Sanjeev sir suggested, during the panel discussion, we will be showing you the complete protocol which can be used by the clinicians. After you take a detailed case history, next we need to know in what all situations we need to be assessing the child's fluency. See, one thing about stuttering is quite variable in nature. It's not same. Like the way it is at home, it's not same when the child comes to the clinic. The way it is with parent, it's not same when he is talking to strangers. Okay, so we need to make an attempt in assessing the child's fluency in variety of speaking situations. So what are the different speaking situations we can target as a clinician is that initially to build some rapport, allow the child to interact with the parent first. It should be like a play kind of an activities. You spread the mat, get all the toys, picture books. Nowadays you can use laptops, mobile phones, and all those things. Okay, animated pictures, they enjoy looking at animated pictures and videos. Okay, so those videos or something, playing those, showing those images, you try to elicit speech from the child. Okay, so typically 10 minutes of spontaneous speech sample interaction, conversation speech, which you should be recording. You also need to record story recall task, storytelling task, picture description task. So SSI has some very interesting pictures. Like there are those, pictures where dinosaurs are there, planes and all those things. Children enjoy looking at those weird pictures. Okay, so they will be more spontaneously, they'll be coming out more utterances when you use those kind of pictures. You can also use images which are given in SSI, certain severity instrument also. Okay, so record speech, parent-child interaction, clinician-child interaction, story telling task, picture description task, so that you know how the child's nature of stuttering across different situations. So whatever I was talking about, recording the speech in variety of situations, that has to be audio video recorded so that you observe both the core behaviors of stuttering as well as the secondary behaviors of stuttering, like escape behaviors, all those things. It's not a difficult task nowadays because most of the clinicians will have their own mobile phones. They have high definition cameras. You can just mount these mobile phones on a tripod or on any kind of fixed surface, record so that you have the video evidence. So as per the research evidence, we need to have at least 500 syllables of speech recorded so that you can observe how the discrepancies are varying in that length of the sample. Okay. Why 500 syllables? Why not 100 syllables? Why not 1000 syllables? See, when you say 100 syllables, you may not be able to observe all the only fewer number of syllables. Okay, so it could be that child may be having more number of display episodes just because that amount of sample which you have taken is so less, you won't be able to clearly observe all the displays. Now, why not 1000 syllables? 1000 syllables, again, it will be really tedious task for you to record, analyze all those things. So it may be time taking for a practice today assessment. So for research, if you can do, very good. For but a clinician, ideally it's between 300 to 500 syllables is what we recommend, so that you have adequate number of syllables to observe the certain distances. Okay, so evaluation of fluency as such it's a very difficult task, because as a clinician you are making these judgments about nature of disfluencies. Okay, so it could be that you have a normal non-fluency child, you have a stuttering child. So your evaluation should lead to ideal diagnosis of the child, so that you don't misdiagnose the child and you end up in doing all wrong things. What I mean by that is that you imagine you have a stuttering child and your assessment is not adequate enough, that the child get misdiagnosed as normal non-fluency. So you are allowing the child stuttering to grow. Okay, or you are misdiagnosing a normal non-fluency child as a stuttering child, and you start treating a normal non-fluency child. Again, that is a problematic thing. So in that way, our observation, our judgment, our inquiry has to be accurate, so that you make the correct diagnosis. Okay, so the first measure which we take when we do the fluency assessment is the frequency count of disfluencies. Okay, so most widely used measure of stuttering is this counting the number of syllables stuttered. There are two types of frequency which you can count. You can count out either the words, or you can count syllables. Okay. Why syllables? Because most disfluencies are within word disfluencies. So hence we recommend documenting percentage of syllables stuttered instead of percentage of words stuttered. Okay. For example, you have a multisyllabic word. Okay, so he may stutter on the first syllable, second syllable. If you take percentage of words stuttered, you are only counting that whole instance as one disfluence episode. Actually, there are two disfluent episodes, because he is having disfluencies on two syllables. Okay, so that will be like you will be your assessment will be under assessment if you don't take the percentage of syllables stuttered. Okay. So how do we count percentage of syllables stuttered? So you have the number of disfluencies divided by total number of syllables into 100. Okay. So I have given an example here. Imagine the child spoke 1376 syllables. In that, 46 syllables were stuttered. Okay, so 56 syllables were stuttered. So you have 56 divided by 1376, which comes to around 4.1 percentage. Okay, it's as simple as that. So you just count the percentage of syllables stuttered. So denominator is number of syllables the child has spoken. Numerator is number of syllables which were stuttered. Okay. In the clinic, most of my students, they no more do this, orthographically transcribing and counting the syllables stuttered. They have this fast method of counting the syllables in this table kind of thing. We have shown here. You have these dots. So what are the different disfluent episodes which we need to count when we count disfluencies? So commonly used criteria is that we only count part word repetitions, word repetitions, broken words, and prolonged sounds. Okay. When it comes to word repetitions, we have only specific type of word repetitions counted. That is monosyllabic whole word repetitions. If the words are, if the repetitions are of multisyllabic word repetitions, then we don't include them in the display, counting the syllables stuttered. We only count monosyllabic whole word repetitions as stuttered episodes. Okay, so part word repetitions, monosyllabic whole word repetitions, broken words or blocks, and prolonged speech sounds. Only these disfluencies are counted as stuttering episodes. So this is a uniform criteria used worldwide by most people, most of the clinicians. So apart from this, there is also this Yairi and Ambrose criteria, where he has given stuttering-like disfluencies and other disfluencies. The stuttering-like disfluencies are your sound repetitions, part word repetitions, single syllable word repetitions, and dysrhythmic phonations. Under dysrhythmic phonations, you have the prolongations and broken words included. The other disfluencies are your multisyllabic word repetitions, phrase repetitions, interjections, and revisions. So we don't count the other disfluencies. We only count the stuttering like disfluencies when we count the percentage of syllables stuttered. Okay, so not all the disfluencies are included, only stuttering like disfluencies are included when we count the percentage of syllables stuttered. I'm stressing this point because you need to be very careful when you are counting the disfluencies. Okay, one another measure which can be used in the clinic is frequency of particular type of disfluency. That is, you have all the disfluent episodes measure for different types of disfluencies. Then you count only particular type of disfluency, that is percentage of repetition. So I'll give you example of here. Okay, so you have the part word repetitions, sound prolongations, monosyllabic whole word repetitions, broken words. So together the whole percentage is coming to 100%. But when it comes to counting, we only count if you want to see how many are part word repetitions. 56% of our part word repetitions, because you have the total number, all the disfluencies counted, that compare it with a particular type of disfluency. So this will give you frequency by type of disfluencies analysis. Okay. So apart from this frequency counts, one another measure which we commonly use in the clinic is duration of within word speech disfluencies. So how long was the repetition? How long was the prolongation? How long was the broken word? So how do we calculate? So you have nowadays, mobile phones where you can analyze for how long each of those disfluent episodes were. So by using a stopwatch in your mobile phone, you can say each how long was the display repetition, how long was the prolongation. So we usually calculate the duration of 3 longest disciplined episodes. So by that which we use, we can also take that measure for measuring the severity of stuttering. Okay. The next measure which is important, which it needs to be calculated when it comes to assessment of stuttering, is rate of speech. Okay, so rate of speech is you have already recorded spontaneous speech sample. Okay, so you can calculate the rate either in terms of words per minute, syllables per minute, or syllables per second. So I have given an example here. If your spontaneous speech sample was of 1245 syllables spoken in 6.5 minutes. Okay, so you have that total number of syllables divided by the time will give you the total number of as 184 syllables per minute. Okay, so in that way we also calculate the rate of speech. Okay, so speech rate has a two-way kind of an interaction when it comes to stuttering. One, stuttering frequency decreases when the speech rate decreases. This is what we commonly use in the clinic, right, as a prolonged speech therapy. When you reduce the rate of speech, okay, automatically stuttering episodes come down. Second kind of a relationship is the inverse relationship. When you have longer disciplined episodes, okay, that also reduces your rate of speech. So in that way, stuttering has both direct as well as inverse kind of a relationship. Okay, so what are the different limitations of speech rate measure? Okay, we don't know what is normal when it comes to rate of speech, because most of us don't use one fixed set of rate of speech. We either speak at sometimes really slow, sometimes really fast, depending upon need of the situation. But around 200 syllables per minute is what we consider as the average rate of speech in when it comes to calculating the syllables per minute. Okay. The next measure which we use in stuttering assessment is speech naturalness. There are different naturalness rating scales are there, but most commonly used speech naturalness rating scale is given by this Martin et al. 1984. It's a 9-point rating scale, okay, where 1 indicates highly natural and 9 indicates highly unnatural. So you have on a scale where 1 is there, highly natural sounding speech, 9 is there, which is highly unnatural sounding speech. So you just listen to the child speech sample and mark the naturalness. Is it 2? Is it 3? Is it 7? Is it 8? Depending upon how do you find child speech naturalness is. Okay. So just listen to the child speech sample and rate the naturalness of speech. Okay. Then you also need to document about indicators of awareness, whether the child is aware about his stuttering. Typically in young children, tension, okay, swab substitutions, okay, increase rapid utterances of part word repetitions are all instances of awareness. Okay, tense body movements. So you need to document these apart from what you observe as repetitions, prolongations, how these disciplined episodes are. That can give you some indication about child's awareness about his own stuttering. Okay, so moving on to calculating the severity of speech, the most commonly used severity of rating the stuttering severity instrument. I'll be talking about this in my next slide. But you also have other tools which are easy to use. Even if you don't have SSI in your clinic, you can still use a 10-point scale of stuttering severity given by these people, which is easy to use. You just need to rate the severity of stuttering on a 10-point rating scale, where 1 indicates normal speech and 10 indicates extremely severe stuttering. Okay, so you can mark the severity of stuttering on a rating scale also. Or if you have severity of stuttering tool in the clinic, you can also use SSI-4. Okay, so currently we have SSI-4 in the clinic. When I was teaching for the students, we usually used SSI-3 also. This is a tool which has 3 parameters when it comes to assessment of severity. You have the frequency, duration, and the physical concomitants. Okay, so I will be explaining this with this image. I hope the image is clear to all of you. Okay, initially you take all the demographic details, then you have 2 tables, readers tables, non-readers table. In readers table, you have 2 tasks, reading task, speaking task, and for the non-readers, it is only speaking task. So you have already calculated the percentage of syllables stuttered in the first this one. So if you feel if the child stuttering is coming to around 13 to 20%, you just give a score of 8. If you feel child has only 4%, you give a score of 5. Okay, so you have this speaking task, reading task, depending upon what is the percentage of syllables stuttered, you assign this score. Okay, so if it is school going child, you average reading plus speech, and then if it is only preschool child, you take only the non-speech task and put the score here. You need to measure the duration of 3 longest disciplined episodes. Mark the duration. If it is 1 full second, then you will give a score of 6. If it is 5 seconds, give a score of 12. If it is each of those disciplined episodes for 1 minute, you give a score of 18. So put the duration score here. You also document the physical concomitants, okay, which are associated with the core behaviors of stuttering. These physical concomitants are in terms of distracting sounds like a noisy breathing, clicking sounds, jaw jerking facial behaviors, tongue protruding, jaw muscle tension, back or forward head movements. So you say how are these physical behaviors in terms of a 0 to 5-point rating scale, where 0 indicates they are not at all there, 1 indicates not noticeable unless you look for it, 3 indicates they are quite distracting, 4 indicates very distracting, 5 indicates severe, very painful to looking. For example, head nods. It could be forward head nods or a backward head nods. You say they are very distracting or painful to look at it. So you give a score of 5 here. So you total that score for the physical concomitants. So now you have the frequency score, duration score, and the physical concomitant score. You give the total score, then you can take the percentile and you can calculate the severity of stuttering. Okay. So, Sanjeev sir, is this table visible?
Yes, sir.
Yes,
Yeah.
sir, it's visible.
So, yeah. So you have separate severity score for preschool children, separate for school going children. So we use a separate data normative for preschool children, separate normative for school going children. So if you feel the total score, which is the average of, which is a combination of frequency, duration, physical concomitants, comes to around 24 to 26. Okay, then percentile is around 61 to 77. You give a moderate stuttering. If the total score is 29 to 31, severe stuttering. If the total score is 0 to 8, very mild stuttering. So using the SSI, we can calculate the severity of stuttering, whether it is a very mild stuttering or very severe stuttering. So you can use these tables. This is a normative which is developed for Western population. So we can take the severity data from them and we can calculate the severity of stuttering. Okay. Same way, we also have severity scores given for adults. So you can use the same tool to measure severity of stuttering in adults. Okay. Apart from these basic measures as percentage of syllable stuttered, rate of speech, stuttering severity, I also said that people who stutter, they have changes in the attitudes, changes in their belief systems, changes towards their attitude towards speaking, towards their stuttering, and all those things. We need to document them because they are also part and parcel of the disorder. So how do we document that? So previously we did not have any tools developed for this, but Jean Bruton and Martin Van Rickham, they come up with this test called communication attitude test. In short, it's called as CAT, which can be used to document negative attitudes in children and adults who stutter. Okay. So this cat tool, it is there for preschool children. It is called as kitty cat. It is there for school going children. It's called cat. It's there for adults who stutter. We call it as big cat. So you have kitty cat, and big cat, which can be used in the clinic. Okay. So I will just give you one or two examples of cat. So it contains 32 statements. Using those statements, the child has to say whether he agrees or does not agree, and based on that you allot a score and you can estimate the negative attitude in that child. Okay, for example, I don't talk right. So child has to say, is it a true or a false? I don't mind asking the teacher a question in the class. True or false? Sometimes words will get stuck in my mouth when I talk. True or false? So depending upon the child's response, we will be allotting a score, and based on that, we will be estimating the negative attitude in the children. Okay. So we have adapted this tool to Kannada language. We have now the normatives developed for communication attitude test in Kannada speaking to school going children, which is we use it for all the children who come for therapy in our clinic. Okay. So another aspect in children is increased anxiety. Okay, to document this, again, Jean Bruton and Martin Van Rickham, they have come up with this speech situation checklist, emotional reaction. This is there for school-going children and for adults. So SSER, whatever I'm showing you is school-going children one. Okay, so again there are set of statements. Children are asked to mark the appropriate answer to these statements on a 5-point rating scale, where 1 indicates not at all afraid, 2 indicates little afraid, 3 indicates more than little afraid, 4 indicates much afraid, and 5 indicates very much afraid. Okay, let's take an example. Okay, talk with a new kid in the school. Are you not at all afraid, little afraid, more than little afraid, much afraid, very much afraid? Okay. Talking during the dinner, when you are having dinner with everybody, with the family. How afraid are you? Talking when you are excited. How afraid are you? Talking with someone older than you. Okay. So you are estimating the emotional reaction of the child in terms of rating on across different statements, so that we know how much is the anxiety in the child towards speech, towards his stuttering. Okay. This again we have adopted into Indian language. Now currently we have established normatives for Kannada speaking children, which we use for all stuttering children in the clinic. Okay. So with that, I come to the end of my first part of the assessment presentation. I have very less left with respect to adults, because most of it, whatever I have spoken, in terms of counting the disfluencies, measurement of rate of speech, measurement of severity of stuttering, measurement of speech naturalness, you have to do the same set of things for adults who stutter also. But there are certain differences in the kind of questions which we ask when adults come to our clinic. First and foremost is whether that is it a developmental stuttering, or cluttering, or neurogenic stuttering, or psychogenic stuttering. So you need to make the differential diagnosis. For a for a child, it was whether it is a developmental stuttering or normal fluency. But when it comes to adult, you have few more disorders added, so you need to be careful. Okay. What does the client seek treatment? Why does the client seek treatment now? Because he's been stuttering for so many years. Why do you think he needs to take therapy? What should be the goals of therapy? So your assessment should help you towards that. Okay. How the discrepancies are affecting the individual's communication? How the discrepancies are affecting his quality of life? Okay. So this was not discussed when we talked about children, because these are the more relevant questions which we need to be asking when we assess adults who stutter. Okay. So the first part which we talked about when it comes to assessment are exactly same: frequency, duration, physical concomitants, naturalness, rate of speech, severity. We do in adults also. So apart from it, like I said, we also need to assess their attitudes towards communication. So we have the big cat. So again, this is a 35 statement screening tool which can measure the speech associated attitudes in adults. Okay. For example, there is a statement like, there is something wrong with the way I speak. You say whether it's a true or a false statement. If the person says true, he gets allotted to a score. So you take the total score, you can estimate the negative attitude in the person who stutter. Okay. So that the way I speak makes favorable impression on people. True or false? When I speak, some sounds or words will get stuck in my mouth. True or false? Okay. I'm sometimes embarrassed by the way I speak. True or false? So you are asking the adult to mark whether it is a true statement or a false statement. If it is a true statement, it suggests that there is some kind of changes in the attitude. Okay. So we have the cutoff score. We look at the cutoff score, and above that it is considered as negative attitude. Below that is considered as positive attitude, or no changes in the attitude. So we have again adapted this tool, Big Cat, to Kannada language. Okay, we have the normatives established, and currently we are using this tool in the clinic for all our adult clients. Okay, so we have the tool ready now. Other than this, there are other tools. We have the unhelpful thoughts and beliefs about stuttering. In short, it is called as UTBAs. Okay, so UTBAs is a 66 item tool. We have the short version now of UTBAs, which has only 6 questions, which can be used to estimate the unhelpful thoughts and beliefs about stuttering. So there are these statements in the tool. I have only taken few statements here. For example, it's impossible to be really successful in life if you stutter. Okay, so this is a thought the person who stutters has about himself. Okay, like, if I'm stuttering, I can't become a successful person. Now, for this thought, we are asking how frequently you get a thought like this. So he has to rate, is it 1, 2, 3, 4, 5. Now, how much I believe in these thoughts? I may be getting these thoughts. Do I believe in these thoughts? Again, the client is asked to rate on this 1, 2, 3, 4, 5, and how anxious these thoughts make me feel. Okay, so in terms of anxiety, because I have these statements, they make me very anxious person. Okay, so like this, There are 66 statements which can be used, the longer version of UTBAS, or you have the 6 statements which can be used in the clinic for a screening purpose in terms of UTBAS scores. Okay, so based on the UTBAS data, you can also recommend your clients for anxiety assessment, and that can be targeted during therapy. If you feel there are these changes in the attitudes, beliefs, that needs to be targeted by a psychologist. So we recommend the client based on their UTBA scores, do they require psychological assessment, and you then both as SLPs as well as psychologists, both of us can work on the individual. Okay. So this is one another tool which measures the impact of stuttering on the individual. This is an indigenous tool developed by Dr. Pallavi Kelkar and Dr. Geeta Mukundan in Indian context. This was Pallavi's PhD thesis work. This is an 100-item tool. It has 4 subscales on measuring the impact of stuttering on the individual. In short, ISACs. So there are these body functions, okay, personal contextual factors, activities and environmental factors, and the last one is about participation in terms of quality of life. Okay, so the respondents are asked on each of those statements on a 5-point Likert scale rating. Okay, 1 indicates low impact, 5 indicates high impact. I'll give you some examples of these tools from certain some sections. For example, section 1 is about activities and environmental factors. So there is one question like this, how difficult do you think the following situations would be for you? Okay, continuing a conversation with a group of people for 10 to 15 minutes. Not at all difficult, very much difficult, somewhat difficult, very difficult, extremely difficult. Now, how difficult do you think the following when you speaking to a large crowd over a microphone? Not at all difficult, extremely difficult. So you are assessing the impact of stuttering on these several questions like this. So there are 100 questions on different sections. Okay, so this is about quality of life. How much, according to you, in your speech negatively affecting the following: relationship with the friends, not at all affecting, a little affecting, somewhat affecting, a lot it is affecting, extremely affected by the stuttering in terms of relationship with the friends, relationship with the neighbors. Okay, so there are these sections on which you obtain the scores, and then in the total you can calculate the overall impact of stuttering. Okay. The last tool is overall assessment of the speaker's experience of stuttering, OSS. Again, this is now adapted to Indian context also. That's why I've kept this tool also. So this is based on the ICF framework. Again, assessing the quality of life in persons who stutter. Again, this can be used clinically, and you can measure the quality of life of persons who stutter. Okay, it has again different sections and different aspects. Okay, so you calculate the impact score and you can estimate whether it's a mild, moderate impact, severe impact on the person. Okay, so overall, when it comes to assessment of stuttering, a detailed case history is necessary. You need to analyze discrepancies, frequency, duration, physical concomitants, estimate the severity of stuttering. You can use stuttering severity estimate, measure the negative associated attitudes and anxiety. Okay, so do this before therapy, immediately post therapy, and during the follow-up sessions also, so that you are knowing the effect of therapy on the individual by documenting all these things. Okay, so with this, I complete this presentation. Thank you all for your patient listening. Sorry for all that interruptions which happened during the presentation. Now we can take some questions. Sanjeev sir?
Yes. Uh,
Okay.
Thank, thank you, sir. Thank you, sir, for the nice presentation. And whatever technical glitch was there is from our side.
No, no, it
Now I
happened
would
from my side also, but I don't know why my this thing video is still not coming.
now I would like to request Sanjeev sir to share his inputs.
Thank you, Chandan sir. And what Santhosh sir has explained, that's from the fluency perspective. But I would like to have my opinion from a clinician's perspective because I am working for past almost 24 years. First thing is that like whenever we are dealing with a patient with stammering, stammering doesn't have any medical manifestation. So if a patient comes to us and if we don't talk about the various aspects which Dr. Santosh sir has mentioned, so they consider fluency problem is just like he speaks very fast and he interrupts at few places. So if clinicians are not able to justify that how deep rooted problem this is, what all it includes, we are surely going to lose our credibility. And it's very important for a private practicing SLP because first time when you meet and you get a 30-minute time to explain things, if you are not documenting these things in a proper way, I feel patient is not going to get satisfied with you. So whatever sir has mentioned, I believe that all the clinician has to take into their consideration that when they try to answer it out, it shouldn't be just mentioning repetition, hesitation, and few secondaries. You have to explain about the technical aspect. Second thing, what I mention is that whenever we are working in a setup where we constantly see one type of patient, we have a format and we follow it out. But when I talk about an average clinic, we have got different type of patients. So once I finish giving therapy to a small young child with auditory training program, and once it get finished and a patient with a fluency enters to my room, he tries to match it that am I at the right place, will I be getting answer to my problem. So clinician has to be in a better understanding of things that how he has to switch his gears from one problem to other. So I feel all of us as a clinician should give a deep thought to what assessment plan Santosh sir has suggested. Chandan sir?
So there
Yes,
are some questions. Should I answer them now or
Yeah,
we'll
sir.
wait?
Yeah,
yeah,
what
yes,
has
sir.
come?
Yes, sir. We'll take few questions, sir.
Okay. Some of them were put on the chat. This thing.
Yeah, yes, I am taking from the chats only.
Okay, okay, fine, sir. You can read
Yes,
one
sir.
question so that we can discuss. Yeah.
Yes, sir. Yes, sir. The first question is what you say on normal non-fluency. What percentage of them you think will continue to become a stutterer? Sir.
Okay. So there is clearly no overlap between nominal fluency and stuttering. They are two separate entities. Just that both appear at the same age range, between 2 to 5 years of age. There is a lot of confusion among the clinicians, whether child is stuttering or normal fluency. So normal non-fluency children, they don't exhibit stuttering dysfluencies. Okay, so normal non-fluency children are typically characterized by multisyllabic word repetitions, phrase repetitions, interjections. Okay, those kind of dysfluencies. Whereas stuttering dysfluencies are within word dysfluencies. They are in terms of syllable repetitions, prolongations, blocks. If you observe a child with syllable repetition, you should be worrying whether, because the child may be having stuttering. If you don't observe syllable repetitions in nominal fluency children, because they are more with respect to multisyllabic word repetitions, whole word repetitions, kind of a thing. Okay, so there is no need to kind of a confusion with regard to nominal fluency and stuttering. What about the intervention for nominal fluency? We don't do anything with nominal fluency child. We just counsel the parents about in terms of reducing the load on the child. Parents should speak slowly with the child. Environmental modifications. Okay, they need to use simple linguistic utterances. They need to be using shorter sentences. Okay, they need to give more time for the child to complete whatever he's trying to say. Okay, so these kind of
Yes.
things are practiced with normal non-fluency children. Whereas stuttering children, even if it is 2 years, 1.8 years, or 2.5 years, we target them during therapy. We work on these children. We don't wait for therapy, the stuttering to reduce itself. So you need to, if you diagnose the child as stuttering, start treatment as and when you diagnose the child as stuttering.
Yes, sir. Our next question is, sir, why do we do backward counting during a stuttering assessment? Should an SLP give intervention for a child with an NF?
The second question I've already answered,
Already
sir.
answered, sir.
Yeah.
Yes.
So the first question, we don't do backward counting during a stuttering assessment. Like I mentioned, we only do spontaneous speech task, like parent-child interaction, clinician-child interaction, story narration, picture description. That's enough. If the child is not cooperative, then you can just initially build some rapport by asking him to count. I never did any backward counting task. If you feel that there should be some kind of a load on the child with regard to memory, you want to see how his stuttering behaves when there is a load on him, then you can do all these backward counting tasks and all those things. Otherwise, it's not necessary, because nobody does backward counting tasks during normal speech. It's just you need to assess the child in normal natural situations.
Yes. Yes.
Yeah.
Sir, could you please explain how the table with and oblique is used to count disfluencies?
Explaining the counting the disfluencies, sir.
Yes, sir.
Yeah, okay. So imagine, sir, there are 100 syllables. Okay. So in that 100 syllables, 14 syllables are stuttered. Okay. So when I say stuttered, these stuttered syllables are only in terms of part word repetitions, prolongations, and blocks. Okay. So if these 14 syllables were stuttered, so you divide 14 syllables by 100, so you will get that into percentage, so it will comes to 14%. Okay, it's a very simple formula.
Yes, sir. Sir, could you explain about our protocol draft, because there is a question related to it. Will all these checklist and assessment be shared with us?
Yes, it will be shared on the Isha website. If they are all the members of Isha website, then they can access this share final protocol. Once Isha EC approves the protocol, we'll be uploading it on the Isha website. Everybody can access to the Isha website.
Yes, sir.
Sir, I have another question. Like, if we come across a patient who has got misarticulation and stammering problem both together, so while taking a call for a treatment approach and counseling the parents, how are we going to move in this case?
So target both. So target both. Divide your therapy session, first 15 to 20 minutes articulation therapy, next half an hour fluency therapy. They, kind of complement one another. If phonology improves, fluency also improves. If fluency improves, phonological, because they are from the same base. The base is same. Why I'm saying this is because 40% of children who stutter, they also have phonological disorder. That means to say, like almost half of children who stutter, who develop stuttering, they have phonological deficits. So we need to be targeting them. We should not be neglecting any one of them. Like you keep working on the fluency so that stuttering will keep growing, right? So we should be targeting both during therapy. Target both phonology as well as stuttering.
I have question related to how to select, how you selecting which approach should be applied for stuttering.
Sir, next talk is on preschool children. Dr. Divya Seth will be presenting on preschool children. How do we select therapy? So if the person can wait till next week, they'll get complete answer for what to do with preschool children, which approach to select, what to do with school going children, which approach to select, and what to do with adolescent and adults. So we have planned that webinars in that way so that all the questions regarding therapy are answered.
Thank you, sir.
Sir,
Yeah, I
go
will not
ahead with.
answer now. I leave this question for Divya and Rakesh and Dr. Pallavi to answer. Yeah, we will
Yes,
during
sir.
panel discussion again we can take up this question. Yes, sir. Yeah.
Sure, sir. Sure, sir.
If there are any assessment questions regarding nature of stuttering, we can definitely discuss now. Yeah.
Sir, can
No,
I
sir.
ask one thing, sir? Just a
Yes, sir.
last
Please
question.
continue,
Yeah.
sir.
Sir, you had mentioned about few assessments with respect to the situation analysis and all. So, what do you think? What should be our approach? Like we have done the assessment part. We started with the therapy. Do we need to have a cutoff like this amount of improvement we have noticed, and then we should go for a hierarchy analysis, like in which situation do you find more problem and this assessment? Or in the very first session you feel that we should go for it?
So assessment has to be done at least 2 sessions, 2 to 3 sessions for children who stutter. Don't we should not diagnose a child with one sitting. We should take at least 3 sittings to diagnose a stuttering, so that you can observe how much is the variability in the nature of stuttering, so that you have the complete picture about severity of stuttering. The stuttering of our own studies, we have noticed the nature of disorder, severity of dysfluencies may vary from 5% to 25%. Like we have done one study across 5 days. First day it was 5%, by fifth day it was 25%. Same clinician, same situation. So we need to record baseline at least 3 times. So with respect to cutoff, you are asking, sir, minimum 5% dysfluencies have to be observed to diagnose it as stuttering. Some people are very stringent that they go up to 3%, up to 3%. But within the clinic, if you feel you are giving therapy within the clinic, the dysfluencies are less than 5%, you can go to the next level. Like you are working on conversation task, you want to move to narration task. So if you feel for 2 3 sessions continuously the disfluencies are less than 5%, then you can move to the narration task. And again, if you feel after 3 sessions, 4 sessions, continuously the disfluencies are less than 5%, then you go to the generalization with the next clinician or generalization with the strangers. Transfer the skills to telephonic conversation. So 5%, less than 5% should be the realistic target which we should keep in the clinic.
That is challenging for the private practitioners, sir. They need to finish assessment in one sitting.
So that's what, sir, we will not be knowing the exact nature of severity of stuttering if we do one sitting assessment, because that day his brainstem may be really fine, everything is working fine, so networks are working smoothly. You may say that very mild stuttering, but after a week, because of some emotional situations, his stuttering will revert back to his old nature. So please don't either discharge the client within a single day. Like wait for at least 2 3 sessions. See the disciplines which have decreased are stabilized for 3 sessions, at least 3 sessions. Okay, continuously 3 sessions, the disciplines are like 0%, less than 1%. Then you are sure that your therapy is working. So you can be sure and you can discharge the client.
So can we have this documented on your proposal of assessment, because that will be easy for us to work it out in a private setup, that we
Yes,
need
sir.
3 days of session for assessment.
Yes, no, 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 minimum 3 days.
Fine, sir.
Because for children, they first day itself they need to build some rapport. You can do the detailed case history. You can finish all those things, build some rapport with the child, play with the child. Second session you can record some tasks like parent-child interaction, picture description task. Third session, by then you child would have got adapted to you. Mainly for children, I'm saying this. Okay. By third session, they'll be more open about when it comes to interacting with you, conversing with you. So by third session, you can do clinician-child interaction, all those things, so that it will be easy for you to document the nature of stuttering. So one
So
thing which
for,
I
for
also
this
recommend
for
more.
this for this what I do, sir. Just I would like to
Uh,
add.
yeah.
I ask them that you have anything recorded in your mobile.
Yes,
past.
yes,
So I
yes,
correlate. I see that probably he's hesitant at present. But if I
yeah.
see the previous sample, then I can guess it. What is the severity of a stuttering?
Yes, we can also tell the parents also to do this at home. They can record. So that's one, one of the advantages of smartphones nowadays is anybody can record from home and they can get the samples to us. That will reduce the burden on us.
Yes, sir.
So that way, in child speech gets recorded in the natural setting at home. You know how child's behaviors are at home. Very good thing for us.
Sir, we have one last question related to assessment part, sir.
Yeah.
He's asking that there were columns with comma and oblique for counting disfluencies in a speech sample. How is that used?
So, like I said, you are conversing with a person. This requires some kind of a practice. We can't be doing straight away with this. When the person is speaking, you can use dot for every fluent syllable and a slash for every disfluent syllable, stuttered syllable. So that you don't have to sit and orthographically transcribe the recorded speech sample. You can also do that if you have time. So even if you don't have time, you can simply use this dot and slash kind of a criteria. Even SSI recommends this. That's why I'm saying this. I mean, it's not just, we do it in our clinic. And Riley suggests this. Okay, so you can use it in the clinic that use dot for every fluent syllable and use slash for every stuttered syllable. So you
Yes,
count how many dots are there, how many slashes are there, divide the number of slashes by number of dots.
yes, sir.
There are some softwares
That will be like a
also.
total number of disfluency divided by total number of syllable or word.
Syllables. Yes, sir, exactly.
Yes. Yes.
And there are some softwares also which can be downloaded from if you have iPad and all. But that requires some kind of an training to use those keys. So I do traditional way in the clinic because I can go back and check on all those things. So we always recommend students to check whatever they have accounted, is it accurate and all those things. Yes.
Yes. Thank you, sir. This was our last question.
Now I request Mr. Chandan for vote of thanks.
Thank you, sir. I I take this opportunity to thank many on today's session. No doubt, first of all, I thank Dr. Santhosh sir for being the lead resource person for this Fluency Friday series. And we all are really fortunate today to get such a depth insight of stuttering and its assessment procedure. Sir, your expertise and command on subject got reflected in your remarkable presentation. Isha SIG speech extends heartfelt thanks for your support in drafting a stuttering assessment protocol. This definitely going to be helpful to all of us for clinical correlation. I extend my thanks to our national coordinator, Sanjeev sir, and our advisors working hard to organizing this scientific series. I sincerely acknowledge to all the delegates for taking out time this afternoon to attend this webinar. A very special thanks to Isha office for supporting us for organizing this webinar. Thank you. Thank you so much once again, sir. And here is a reminder to register and attend our upcoming session on 9th September, as already sir mentioned. And topic of session is management of stuttering in preschool children. And a speaker is Dr. Divya Seth. And for the session, moderators are Miss Sunali V. Dhawan and Miss Yashna R. Haryani. See you all again. Thank you.